Welcome to AETCM. Today we're going to discuss a case about an RTA, a 15-year-old child who got into an RTA. Okay. Shall we begin, sir? So this is an RTA, a 15-year-old child about a weight of 35 kg who got into an accident, the car versus wall direct hit, sir. So the patient was brought in a trolley. On arrival, Pat's rank for initial arrival, she was brought in a trolley and she was crying from the time itself. And on arrival, on the appearance, the child was crying and the eyes were closed and she was moving all her limbs.
Okay.
And breathing, there was fast.
So can you just brief me what is the mechanism of injury? If you know anything, if you can tell.
So at that point of time, we didn't know the mechanism of injury. We know that
the child was wheeled in following an RTA to the ER. A 15-year-old child, she was crying and she was moving all four limbs. Yeah. And any bleeding, external obvious bleeding that you could see?
We could see that on the right forehead there was a lacerated wound and bleeding was there.
So that is your initial impression that you got from the child. So you quickly have gone for a 10-second assessment. You have got a child approximately 15 years of age, weighing around 40 kg. And the child is moving her forelimbs and she has got an active bleeding and she's crying. Right. And she's talking or she's able to communicate with you?
She was talking but she was not responding to her commands.
Okay, so there was verbal response. So we consider with AVPU, we can put it as V, and the child was moving around all four limbs. So that is it. Okay.
So other than that, she was not following command. On primary survey, the airway seems patient as she was talking to us.
Okay. So what are the questions that you wanted to clear in the airway? So what are the questions that you need to answer? So what are the leading questions that you will ask in the airway for any trauma patient or any patient that is coming to the ER?
So initially we started with what's her name? Like that we started.
No. What are your concerns regarding airway?
So asking an RTA. The main concern was how's the mechanism of injury and whether is she had any trauma to the neck or chest.
Here two concerns. One is whether the airway is patent.
Airway is patent and whether the airway is maintainable. These are the only two questions that we need to answer. The airway patency can be obstructed due to a foreign body or due to a tongue fallback or due to a decreased response because of the RTA itself. So maintainable, patency. So these are the two questions that we need to answer. So these two questions we need to be clear and we have to see whether there are any added sounds to it, like stridor or you are hearing some gurgling sound. So gurgling sound you need to clear the airway by doing a suction. And stridor is that there is some upper airway obstruction. So these are the things that we are concerning regarding our airway and you have to assess the airway and do the maneuvers whatever is needed. Maybe a simple chin lift maneuver will help her here, but head tilt you cannot do here because we are suspecting a cervical spine injury also being an RTA. So you can do a jaw thrust maneuver and you can open up the airway. So these are the questions that you have for airway and you need to clear those questions. And here again it is a trauma patient, so A is for airway with cervical spine stabilization. So you have to consider cervical spine immobilization also. So being a 15-year-old or 10-year-old, whatever be the age group, you have to consider that also. So how will you do a cervical spine mobilization for this child?
So in this part, as the patient was agitated, we couldn't assess how much, whether is there any C-spine injury or not. And
so that unless and until one, you have to take it to consideration that she has got a cervical spine injury. So if you use your nexus criteria, alternate mental status, your alternate mental status, there is one point is positive. So you go ahead and put a cervical immobilization. So that is immaterial. Whether the patient you are able to assess or not able to assess, that is immaterial. If you suspect, you immobilize the cervical spine.
And we, but that time itself, we put her on C collar.
So the challenge here will be a 15-year-old, what size of cervical collar that you wanted. If you have an universal collar, you can adjust it according to the length of the cervical spine. After measuring, you can do. But otherwise, medium, large, all those things, it should be correctly fitting cervical collar you need to choose. So that is again one of the challenge that is in pediatric trauma that we need to face. Sometimes we need to have some customization also. So we don't know how, because a small child comes, sometimes we will not be able to get an ideal cervical collar. So we need to create a cervical collar customization, all those things we need to think what all things we can use for immobilizing a cervical spine in a pediatric trauma. Right.
Yeah.
So that is your airway with cervical spine stabilization. Now coming to B.
Breathing, she was having a fast breathing And on auscultation, the chest was clear.
Okay.
Air entry was bilaterally.
So again, similarly in airway, what are the questions that you need to ask in breathing? One is respiratory rate, that you have already said the child was tachypneic. So what was the respiratory rate of this child?
Rate was 24,000.
So for a age group, so is 24 is on a higher side or on the normal side?
It's upper limit.
It's upper limit of the normal. So 24 means it's upper limit of the normal. So it is accepted that maybe due to pain, anxiety, the respiratory rate might have gone up. Then the second thing, what is the type of breathing? Whether the accessory muscles of respiration is active or she's having more of an abdominal breathing. This is an RP. If there is a chest injury, they have a pain refracture, they will not move that area. So what type of breathing that she's having? Whether she's tachypneic or next thing, what is accessory muscles are active or there is any asymmetry in the chest movements. One side is moving, one side is not moving. All those things we need to tell. So, what is the assessment on it?
So, an assessment, at that point we haven't done the exposure part, but
Why you want to do the exposure part? You have to expose the chest, definitely. You need to expose complete body. We have to definitely expose the chest and see how is the chest movements are. It is very mandatory. You need to see there is adequate chest rise on both the sides. Because mechanism of injury, we doesn't know anything. So that has to be done. Then next thing is you have to connect to the monitor, see what is the saturation. Saturation less than 95, you need to supplement her on oxygen. So face mask or Hudson mask. What was the saturation?
Saturation was 98%.
98%. So no need of oxygen supplementation at that point of time. Next thing you auscultate. Air entry, you said bilaterally air entry was equal. You need to look for any other added sound, anything is there. And palpation. Right now we don't do palpation at this point because we are just doing a primary assessment. Primary survey, we just go through the quick assessment of A, B, C, D, E. And breathing, the most important thing, what is the air entry, bilateral air entry, chest movements, and trachea, whether it is central or shifted, or you are suspecting a tension pneumothorax, hemothorax. So these are the life-threatening conditions that you need to have to find out. You have to identify and you have to treat. So you have to identify any of these things are there and you have to treat simultaneously. So oxygenation was fine, ventilation was okay, and breathing patterns looks okay for the time being.
Trachea appeal was generally and chest movements were
Bilaterally present. Okay. Now the next thing.
Next thing, coming to the circulation part, all peripheral pulses were equally palpable.
Okay.
And so there was an active bleeding from the forehead side.
Okay, there was active bleeding from the forehead side.
And
so what you have done for that?
Bleeding was there, but it was partially.
It was arrested, but spontaneously it got arrested. So the patient had an active nasal bleeding, and which got spontaneously arrested. So just coming to blood pressure, should be the anticipated blood pressure for this age group?
So
what is the anticipated systolic BP for her? 70 plus age into 2. So the systolic BP should be somewhere around 80. 70 plus age into 2. 15-year-old.
Yeah, 15.
So what 70 plus age into 2, 15 into 2, 100. As you said, it is correct. 100 should be the systolic blood pressure. So that is the anticipated 5th percentile above the anticipated blood pressure for her age group. What is the heart rate?
Heart rate.
Pulse rate.
Pulse rate will be 102.
So that is not a tachycardia for this age group. So there is no evidence of tachycardia. So that capillary refilling time. What is the CRT?
CRT was within less than 2 seconds.
So there was an external bleeding which spontaneously got stopped. And you said there was some wound over the frontal area. Whether there was any active bleeding?
Yeah, there was active bleeding from that side, but not that much of.
But there was active bleeding. So when you see an active bleeding, what is your first step?
To try to stop the active bleeding.
You have to give a compression. Definitely you have to give a compression and you have to stop the bleeding. So you have identified that there is a problem in C in terms of vitals wise it is fine, but there was an external hemorrhage which you put control because nasal bleed stopped by itself, and the other one you gave a compression bandage. So that is the next thing. So A, B, C is done. Coming to the disability part.
And in circulation part, we that time it's two
large bore IV access. Okay. Okay.
In disability wise, the GCS was E3, V4, M5 as
E3, V4, M5. So it will be moderate, mild to moderate or mild. What will be the total GCS you calculate?
13 out of 15.
So it's a mild head injury. She's having as per the criteria. So she's having a mild injury. So if you are not able to do GCS, maybe for a smaller child, you can go for AVPU scoring also. AVPU, alert, verbal response, painful and unresponsive. So AVPU score can also be done. The next thing.
So pupil couldn't be assessed at that point of time as she was very agitated and.
Okay. So we should assess the pupil definitely.
So, she was moving around so much and
She was agitated. Did you give any pain killers
At
for
that
her?
point of time, so pain severity also we couldn't assess, but she was telling that
Because
she was
if there is an
having,
open
yeah.
fracture here, open bleeding here, nasal bleeding, definitely she will be in pain.
Pain.
So analgesic definitely need to be given. So what you have given?
Initially a paracetamol IV was given, and she was still continuing to be in the pain, and followed by we given a opioid fentanyl was also given.
Okay, so pain management was done appropriately. Okay. Next thing.
Then further exposure was done. Total body exposure was done.
Log rolling and
Log
exposure
rolling
was done.
exposure
There was
was
no
done.
other external injuries.
No other external injuries were noted, and she was moving all her limbs
Okay.
at that point of time. And further, we to prevent hypothermia, the patient was covered.
Okay. Hypothermia was prevented. Next.
So, in adjunct to the primary survey, at that point of itself, we called up the, we did the
Fast.
E-fast was done, and at that point there was no any active bleeding.
So fast was negative. So the first was negative, which you need to, sometimes you need to go ahead and do a control fast. Later, after 30 minutes, we need to repeat. If there is any sudden deterioration of the vital sign, we need to repeat the fast. Okay.
And at that point itself, we directly shifted the patient for CT brain plane with C spine.
Okay. So my question here will be, where does the CT brain? Is it part of your primary survey or part of your adjustment secondary survey?
It is usually a part of secondary survey,
Oh.
and because of the pick and rule where the child is having an low GCS with the history of altered mental status, we
See, definitely this child requires a CT. When to take a CT, that's the only question. So here the child, see, when not to shift for a CT, when the child is having hemodynamic instability or any of this where you CT is not possible, that is the time where you can delay a CT. But here definitely there is only an isolated head injury that we are getting right now from our primary survey. So CT is a priority for her, and for the treatment decision will be done after the CT only, because right now we don't get any chest injuries as such. There is no abdominal injury, there is no long bone fractures. We are only to have probably a brain as well as cervical spine injury, which we are suspecting at this point of time. So definitely, as you said, as per the Pekrine rule, we can need to proceed with the CT. As on presentation, there is a low GC. So when to do the CT, that is the only question. So the simple equation that you can remember, patient is stable enough, you shift for the CT immediately. If you want to resuscitate, you resuscitate and shift for the CT. Ultimately, this patient requires a CT.
so and but that at that point of time we got to know about the history and the
You can do the sample history simultaneously. So any allergies, any medications?
no allergies was there, and she was not on any medication.
So what was the event that got her here?
So the history is that it was a car versus wall accident. Car hit on the wall. The
So she was
a
sitting?
passenger behind the driver.
Okay, so she was wearing a seatbelt or not?
She was
wearing
not wearing a seatbelt.
seatbelt. So she was behind the driver. So sudden force, it has gone and hit to the wall, and that impact has caused this injury. So what all injuries that you will suspect in this patient, in this child?
So she was in the backside of the driver's seat, and also she was not wearing a helmet. So the high chance, not wearing a
Seatbelt, yes.
seatbelt. So there is high chance that
That also is very difficult. If helmet also comes.
so her head got high chance that head injury can occur.
Head injury, cervical spine injury,
Cervical spine
sudden whiplash movement, cervical spine injury, chest injury. Simultaneously, the chest would have gone and hit the seat, and also because she's not in the front, but if it was in the front, each can go and hit the dashboard also. So we can have pelvic injuries and long bone fracture. So ideally, here by this history, whatever we get, it's primarily going to be head injury with the cervical spine injury. Fine. So CT.
Further we did a CT. CT was showing a SH.
Subarachnoid hemorrhage.
And further CT was showing multiple cranial bone fractures also.
Facial bone or cranial?
Cranial and facial bone.
Cranial and facial bone fractures. So what's up? Can you just read out the report?
So in CT there was multiple facial bone fractures and right frontal scattered frontal SH.
Okay,
Scattered frontal SH. Then she was also having
She was also
I think
having
it's also a CSF rhinorrhea.
CSF rhinorrhea. It was it came later on.
Okay.
So bilateral frontal bone fracture was seen
Okay.
with extension into frontal sinuses.
Okay.
Then fracture of ethmoidal septet and bilateral nasal bones. Then fracture in the medial wall of orbit and supraorbital rim.
Can you name this fracture? Before 1, 2, 3.
This will be before 2 fracture with no
craniofacial distension. That is Lefort 3. So it will be more into a Lefort 2 sort of a fracture with a frontal bone involvement also. Okay.
Then
So leave it. So whatever be there are multiple facial bone and cranial fractures. That is okay. But as the patient is back to the ED, so what will be your treatment plan for her? So you have got, okay, this girl is having a subarachnoid hemorrhage, minimal subarachnoid hemorrhage. This patient is having some cranial facial bone fractures. So how will you go about in this patient?
so as she is having multiple cranial bone fractures with SAH and pneumocephalus was noted, and also hemosynus is also noted. So the main thing is that to prevent a brain edema and also to prevent any epilepsy also, there is high chance of epilepsy also.
So we'll just come through, we'll have the first tier. Tier systems are there. So there are 3 tier systems to prevent the raised ICP, to prevent from going to the raised ICP. What are the simple steps that you can do?
So simple step is that head and elevation.
First thing you do the head and elevation. Next thing.
So then to prevent any neck pricks or
avoid compression over the carotids or the venous punctures, everything you need to avoid. If you are intubating the child, you are mounting your ET tube, that should not pressurize and it should not decrease the venous rhythm. Then
we'll start with the IV.
You said the style was agitated.
Analgesic.
Adequate analgesia, adequate sedation as and when required. But that should not hinder your GCS assessment also. So here the child is otherwise, maybe as you said the GCS was around 13. So by sedating, you might be able to hinder that. But you have to sedate the patient to avoid the pain. So when you are giving for some analysis, it will have some sedative effect also. And next thing will be
anti-epileptic measures.
Anti-epileptic measures, okay. Definitely, yes, here there is a compressed bone fracture, there is parenchymal irritation. You can start anti-epileptics and make sure that you are withdrawing the anti-epileptics after 1 month. They doesn't need a prolonged treatment like we give it for the seizure disorder.
Then IV 3% saline can
3% saline, hypertonic saline can be started to, and with the targeting sodium of around higher the normal limit, that is around 145. Then you want to give mannitol for that.
not indicated.
From the CT, there is no signs of any midnight shakes. There's no
Whenever you have features of brain herniation, during that time only you need to give mannitol. Routinely, otherwise there is no indication for mannitol. So suppose you are going to give mannitol, it is going to be a one-time effect. Whenever you really wanted to give mannitol, only you should use mannitol. It should be reserved for that purpose. So steroids. Again, there is no role for steroids, any role, because it's a tumor related thing, there is a role for steroids. Otherwise, there is no role for routine use of steroids. The most important thing in this style or any head injury patient is that prevent secondary brain damage. So that is our priority. So preventing secondary brain damage, one thing is you have to prevent hypoxia. So you have to make sure that the health saturation is being maintained above 95. Second thing is avoid hypotension. So she had some external hemorrhages, all those things. So you have to prevent that and prevent hypotension. So what is the problem when you have hypotension? Why I am saying this?
So the ICP, raised ICP occurs due to
no. What will happen to your cerebral perfusion pressure?
Basically, MEP minus ICP.
Yeah.
So whenever MEP drops, actually the ICP is increasing, can again
further decrease the cerebral perfusion pressure. So cerebral perfusion pressure is your MAP minus your ICP. MAP comes down, ICP goes up. So the difference again comes down. So cerebral perfusion pressure comes down. So again, whatever is happened to the perfusion is low to the brain, further it drops. So that is as a normal mechanism. That is why whenever you have a raised ICP, there is an increased blood pressure to maintain that perfusion. So that is a normal response from the body. So if there is hypotension also, that will further worsen. So one area where you cannot practice this hypotensive resuscitation in trauma is head injury. So head injury, we don't want any sort of hypotension. So we wanted to maintain a normal blood pressure for this patient. So that is very, very, very important. For this child, at least above 100, we need to have sustainedly maintained. If it is coming down, you need to give your fluids and you have to bring up the BP. So that is second thing. Hypoxia, and hypotension. Hypoglycemia, that is the next thing that you need to prevent. And hypothermia. You need to prevent from the patient getting into fever. So these are the three things, and further seizure also we are preventing by giving her antiepileptics. So this patient, ideally as an emergency physician, our aim is to do these things, and we need to start them on an antibiotic. Definitely there is an open fracture, maybe some gram-positive coverage you need to start it. So maybe cefuroxime, maybe for time being that should be enough, and tetanus prophylaxis. Whatever tetanus prophylaxis you want to give, depending upon the immunization status, tetanus vaccine with immunoglobulin, depending upon the immunization status, you need to decide. So that will be the second thing. Next thing is analgesia, then all general electrolytes management, and you have to look in for any other organ injuries is there or not, and you need to involve the correct people for further resuscitation. So whether all fractures, frontal bone fractures need surgery, or which are the fractures that need surgery?
So that's fractures which need surgery is that there are multiple skull fractures. With depressed skull fractures are the one who usually need surgery. In that depressed skull fracture also greater than 50% of depression with like 8 to 10 millimeter depth with other any functional neurological deficits or other than which greater than 50% over inlay of the other bone which is the one who are warranted for surgery.
So the most important thing is more than 50% of the compression, and if it is inlaying on the over and superimposing on the other structure and it is causing further damage, then definitely that patient needs surgery. So then you need to involve your neurosurgery team, and they need to decide. Cranial fractures, all those things can be done whenever the child is stable enough. But this one is very priority because need to be fixed, because otherwise there is a high chance of irritability, further brain damage, seizure potential, everything is going to be on a higher side, and definitely they need a floor repair. Because there is CSF rhinorrhea is also there. So that maybe later on she needs some endoscopic surgeries for do the wherever there is a rent in the CSF, we need to find out where exactly the leak is there, and we need to go about the surgery. So later maybe CSF, cystinogram, all those investigation we need to do. But right now our aim is to stabilize the airway breathing circulation, prevent secondary brain damage. So that is the most important thing. Prevent secondary brain damage, and you start her on anti-seizure medication. You start her on 3% saline acid hypertonic, adequate pain management. This will be our primary aim, and you have to look for any other fractures that we have missed. Maybe we have just missed some major injury. So anything else is there, we need to decide and find out. Maybe you do a detailed secondary survey, and you need to find out whether any other injury that is missed also we need to find out. So that will be the ideal. This here primarily there is a traumatic brain injury. Cervical spine is normal.
Cervical spine was normal.
Was normal. MRI or CT was there?
CT spine.
CT spine fractures. Shigora is one entity that you need to consider. But this child doesn't have got any deficit. The child has deficit and normal CT scan. Maybe an MRI also would have been warranted, because sometimes CT fractures might not be there, and you might get spinal cord injury without any radiological abnormality. So that part also we need to take care. So what was done to this child?
So further, as initially there was no CSF rhinorrhea, and later on she developed CSF rhinorrhea. And following with that, from this, neurosurgery guys were also seeing the case, and OMFS was also seen.
Okay.
OMFS and neurosurgery. Later on, they did a CT face skull, which was also taken to find the actual site of the CSF bleeding and CSF leakage.
Okay.
And it was showing multiple craniofrontal
fractures were there.
And later on, they did a ORI of the
frontal bone fracture. Facial fractures?
Facial fracture. It was not warranted for any
surgical repair. They just went for it with conservative management. So later on, the floor of CSF repair was also done for her, or just open reduction?
After the initial surgical management, the CSF rhinorrhea stopped. And right now the patient is in observation to look for any further
deterioration. Okay. So maybe later on, if she have any CSF rhinorrhea, she needed to have that surgery also to be done. So basically our aim, any trauma primarily coming to us, however, as an emergency responsibility will be to take care of A, B, C, D, that we have already done, and you have to send for the CT. When to send for the CT? That is the question here. And taking care of the secondary brain injury, which often we miss sometimes, but that has got very important priority, because other people, they will be neurosurgery, they will be just concerned regarding the injuries, whatever has happened. The orthopedician will be concerned about the fractures that has happened. Maxillofacial surgeon will be concerned for that. In total, patient will be has to be taken care by the emergency physician. So you have to prevent hypoxia at any cost. hypoglycemia, hypotension, and hyperthermia. So that will be our primary responsibility. Okay. Thank you.